Hello, my name is Dr. Ilias Cagiannos. I'm a urologic oncologist at the Ottawa Hospital, and in this video I will be discussing radical cystectomy and urinary diversion. Radical cystectomy, or bladder removal, is a standard treatment for muscle-invasive bladder cancer and can also be used in patients with non-muscle invasive bladder cancer who have recurrence of disease despite other treatments. When we refer to radical cystectomy or bladder removal, in females, this operation also includes removal of the uterus, the ovaries, the fallopian tubes, and the anterior wall of the vagina. In select cases, vaginal sparing or sexual function sparing cystectomy can be performed. In males, radical cystectomy also involves removal of the prostate gland, as the prostate may be involved with bladder cancer approximately 40% of the time, and this procedure is called a radical cystoprostatectomy. In all patients, both men and women, radical cystectomy also includes removal of the surrounding pelvic lymph nodes, a pelvic lymph node dissection. The pelvic lymph nodes are a common site of spread in bladder cancer, and so removal of these lymph nodes has important diagnostic as well as therapeutic implications. Once the bladder has been removed, the kidneys where the urine is produced and the ureters which drain the urine down to the bladder are now disconnected, and therefore a urinary reconstruction is required. This urinary reconstruction entails diverting the urinary tract from the normal anatomy into an altered anatomic state, termed a urinary diversion. There are 3 options for urinary diversion, and all of these are based on the intestinal tract. In all techniques, a segment of the intestine is isolated from the rest of the intestinal tract, and the 2 free ends are joined back together to reestablish continuity of the intestinal tract. The segment that is chosen to be used, both the length of the segment and the location of the segment, vary depending on the choice of urinary diversion. I will now discuss the 3 different choices for urinary diversion, going from oldest to newest. The oldest or original technique for urinary diversion is what's called an ilioconduit. This is a very basic technique that has been around since the 1940s. It entails using a small piece of the small intestine, approximately 10 to 15 centimeters, that is isolated from the rest of the intestinal tract as previously described. And this is very simply connected to the ureters on the back end. The other end is brought out to the abdominal wall, and an opening called the stoma is created in the abdominal wall, and urine will freely flow out onto the abdominal wall where it is caught by an external collecting device or a bag. The bag will fill, and once full, you will empty it. You will be taught how to empty, clean, and replace the bags. There have been 2 evolutions beyond the ilioconduit to try and eliminate the need for an external collection device or a bag, and also to eliminate the potential odor of urine on the abdominal wall related with an ilioconduit. The first of these techniques is called the continent catheterizable pouch. This technique also uses a stoma. However, this stoma is much smaller, typically approximately 1 centimeter in diameter, and is continent, meaning it does not freely allow the flow of urine out, so no urine drains out of this stoma. Inside, the isolated segment of the intestine is much larger, typically 60 to 70 centimeters of large intestine or the colon. This tube of colon is cut open and detubularized and folded into a pouch or a reservoir. This reservoir has the kidneys and ureters connected to it, so the urine will fill this reservoir. And the main reservoir is connected by a still tubularized piece of bowel to the stoma. As the pouch fills, urine does not come out, and to empty this internal catheterizable pouch, a small catheter will be placed through the stoma approximately every 4 hours to drain the urine. Once the pouch has been drained, the catheter is removed. You do not need to wear a collection device for this. The next evolution is what is called a neobladder. With a neobladder, we are back to using the small intestine, but a much larger segment, approximately 60 centimeters. This long tube is again cut open or detubularized and folded into a reservoir. The kidneys and ureters are again connected to this reservoir, which will now fill with urine. However, unlike the continent catheterizable pouch, which is connected by a stoma to the abdominal wall, the neobladder does not have a stomal opening onto the abdominal wall. Instead, it is connected directly to the urethra or the urine channel, and the patient will void per urethra in a fashion analogous to how we urinate currently. Although this recreates the normal anatomy the closest, there are some issues related to this. Firstly, a patient will have to retrain themselves how to urinate. Currently, when we urinate, we voluntarily squeeze our bladder, we relax our sphincter, which is the small muscle controlling urination in the urethra, and we will void. However, with a neobladder, we can't voluntarily squeeze our intestine. We don't have that ability to control that. In an analogous situation, when we have a bowel movement, we are not squeezing our intestine. We are increasing abdominal pressure, and this pressure will transmit onto the bowel. We relax our anal sphincter, and this propels the stool forward. Voiding or urinating with a neobladder is done by a similar mechanism. So with a combination of relaxing the muscles of the abdomen and the pelvis and some gentle abdominal straining. This abdominal pressure will again transmit onto the internal reservoir, the neobladder, and by relaxing our sphincter, this will propel urine forward. So there is a bit of a coordination where one must relax in one hand, but also gently squeeze their abdomen in the other to help propel the urine forward. There are some difficulties in continence as a result of the neobladder. These difficulties may be with both hypercontinence, or inability to empty, and incontinence, which is the opposite problem, or leakage of urine. With regards to hypercontinence, men do much better with this than women. 90% of men are able to adequately empty their neobladder, whereas 50% of women may have some difficulty emptying their neobladder and be retaining urine within it. In both patients, men and women who are unable to fully empty their neobladder, they may need to perform some form of intermittent catheterization, whereby a catheter will need to be placed through the urethra into the neobladder to empty it. And this catheterization may need to be performed from once or twice a day to as often as every 4 hours. From this, one can see that the neobladder is what recreates the normal anatomy and normal urinary function the closest. However, it also requires the greatest degree of rehabilitation on the patient's part to try and achieve that good neobladder function. And therefore, an appropriate patient for this should be motivated to perform the regular timed voiding, the Kegel exercises, and the practicing of the urinating action that is required to protect the neobladder and lead to its ultimate success. The ultimate choice for urinary diversion is a personal one, and there are patient as well as cancer factors that may help influence that decision. This decision will ultimately best be made after a conversation with your treating surgeon. It's important to note that for those patients who are choosing to have a neobladder, the final decision is made intraoperatively. Approximately 10% of the time, there may be cancer involvement of the urethra. And if this is the case, the urethra will need to be removed, and therefore a neobladder cannot be performed. In this scenario, it is important to have a second choice decided, as this decision is made intraoperatively. The operation of radical cystectomy with pelvic lymph node dissection and urinary diversion will take approximately 6 to 9 hours to perform. You will be in hospital for 7 to 10 days post-operatively. This is one of the largest operations that a urologist can perform, and therefore has a number of potential complications. Overall, approximately 50% of patients will develop some type of complication. Many of these are minor. With regards to complications, we can break these down into short-term or intraoperative complications and longer-term post-operative complications. Intraoperative complications include bleeding, as well as the possibility of blood transfusion, injury to surrounding structures, most commonly the bowel, injury to the nerves related to either the surgery itself or due to positioning during the operation, Intraoperative cardiovascular complications, including heart attack, heart failure, blood clots going to the lungs called a pulmonary embolus, and stroke. Postoperative complications also include bleeding, and again the possibility of a blood transfusion, infections, with approximately 25% of patients having an infectious complication, and this can be either a superficial infection, a deeper wound infection, or a urinary infection. There's the possibility of lymphatic leaks from the lymph node dissection, the possibility of urine leaks from the urinary diversion and reconstruction. There's the possibility of a lazy bowel postoperatively called an intestinal ileus. There can be the possibility of an actual bowel obstruction, which may require repeat surgery. There are wound issues, possibly related to the wound opening up, called a wound dehiscence. There can be stomal complications in patients who are having a stoma, either a retraction of the stoma or stenosis of the stoma or a hernia alongside the stoma. There can be obstruction of the kidneys due to scar tissue called strictures forming at the site of the reconstruction where the ureters are plugged into the urinary diversion. Postoperative cardiovascular complications, similar to what could occur intraoperatively, can also develop, once again including heart attack, heart failure, blood clots, and stroke. Another form of complications that can develop with patients undergoing cystectomy and urinary diversion are metabolic complications. These would be complications such as an acidosis or overabsorption of an acid load, electrolyte abnormalities. You can get some change in your bowel habits. Actual diarrhea is rare, but softening or some change in bowel habits may occur. Associated with this, there can be some malabsorption of some fat-soluble vitamins such as vitamin B12, as well as some other malabsorption. There is a greater propensity to stone formations in patients who undergo cystectomy and diversion, with a 3 to 4% risk of developing kidney and ureteral stones. As well, there can be some mishandling of some medications and some loss in the bone density and bone health. There may also be a decline in kidney function in patients undergoing diversion related to either obstruction, from stone formation, from the strictures that we previously discussed, and from recurrent infections. This video was meant to be an introduction to cystectomy and urinary diversion. Further details will be provided by your surgeon at your in-person consultation.